Good morning. It is August 26, 2021. Our guest speaker is Dr. Dubovoy. Those of you on Zoom, and then we do have an audience here. We appreciate your undivided attention. So thanks so much, Doctor, and you can go ahead.
Thank you, Tricia, and thank you, everybody. Thanks for allowing me this opportunity to speak to you this morning. I wish I was there in person, and I wish everybody was able to attend in person, but we'll do our best with the Zoom presentation. As Tricia mentioned, this is being recorded, and I'm happy to share the slides as well and forward them to your group. But today's topic is going to be update on the perioperative glucose management. The challenge of managing patients with diabetes is not new. As you can imagine, before COVID, this was definitely on the top of the public health hazards. And even today, it is estimated that about 30 to 40% of patients that are being admitted carry the diagnosis of diabetes. And historically, as you all know, this is not an acute disease. This is an indolent condition. And we've always been challenged on how to deal with it in the perioperative environment because our interaction with patients is usually very short and limited. And diabetes is much better managed in the ambulatory setting by primary care providers. And several years ago, the question was raised, what can we do to integrate the care of those patients so that the care, both in terms of the hyperglycemic management, but also any diabetes management is fully integrated. And that means what can the pre-op do that will link with interventions that are happening intraoperatively, will seamlessly transition into the PACU care, and then wherever the patient goes, whether they're being sent home if it's an ambulatory setting, or they're being admitted to the hospital. So the overarching theme here is early intervention and continuation of the intervention. That was really the goal. Now, as you can imagine, this was a major undertaking. And even now, if you look in policy stat, you're going to see divergent protocols. Some of them are historic. The problem is whenever we create one, we never remove the old ones. So this is the part of this effort is actually going to be to clean up everything, all of the outdated either protocols or the guidelines, and replace it with a very consistent and a single approach to handling patients with diagnosis of diabetes in the perioperative areas. Now, this project was started several years ago, actually, and there was involvement. It was led by the hospital endocrinology service with input from all of the areas within the hospital, specifically from the perioperative areas. Denise O'Brien was involved and Noreen Myers was involved from the anesthesia side. Dr. Satish Kumar and then Amy Young and then myself were involved over that period of time. So everybody contributed to this, to the development of this new guideline. Now, unfortunately, the release of this guideline coincided with the COVID pandemic. If you look at the actual dates, this was released last year. It didn't receive the proper publicity. It didn't receive the proper rollout, frankly. The other issue with this guideline is that it is 56 pages long. It is very comprehensive, but it makes it very challenging to actually translate it into the practical steps that can be taken within each individual area. The guideline is comprehensive because it covers the care of diabetic patients, I should say patients with diabetes, on the entire spectrum of the inpatient side. So whether they're having surgeries, whether they're being admitted for medical reasons, et cetera. And that's the reason why the guideline is so complex. Now, the last thing I want to do is get through and bore you by getting through the whole 56 pages of the guideline. That is not the purpose here. We do have to get into some of the details, but the goal today is to really translate it into what actionable steps need to be taken in the perioperative area, both pre-op and PACU, but I think it would be important for you to understand what anesthesia is going to be doing differently intraoperatively. And specifically, how is it different from what we're doing currently? Because we're not just ignoring these patients right now, we're actually taking great care of this patient. So it's important for everybody to understand what are the exact changes and what is being asked. specifically in the pre-op area, specifically in the PACU area, and you need to understand how it interacts with intra-op as well as what happens to the patient afterwards. Now, the other caveat that I want to say is that when we approached it from anesthesia side, we wanted to cover both the inpatient as well as the outpatient populations. And I think it's a very important point. The guideline, unfortunately, that was officially published only focuses on the inpatient side. But towards the end, I would like to share the guidelines that we have been developing internally that would benefit the outpatients as well. And notice I'm saying outpatients. I want to stay away from the word ambulatory because ambulatory usually entails outpatient surgical centers such as East Ann Arbor, Brighton, Kellogg. And we do have a fair amount of outpatients that are being done here on the Hill, specifically at UH, even at CVC. And in practical terms, we really should be delivering the same standard of care across the board when it comes to outpatients, whether they're being done at an ambulatory center or whether they're being done on the hospital side. But they do require slightly different approach because obviously we're going to be sending them home and we don't want to be as aggressive in treating their glycemic abnormalities. So with that preface, I want to dive into some of the details. And again, I'm just going to be focusing on the very select portions of the policy only as it pertains to the perioperative workflow. The first question is, when the patient comes to the pre-op, who is going to get tested in terms of checking their blood sugar? And the answer there is there's not much change from the current practice. Right now, the practice is to test anybody who has known diagnosis of diabetes. And the only other inclusion that was listed here in this protocol is any patient with incidentally noted hyperglycemia. What does it mean? That doesn't mean that you actually have to be drawing tests for no good reason, but it means that if a lab resulted in a glucose abnormality, they would fit within this workflow. Now, those abnormalities can come from different sources. One example that would come to mind is patient with renal failure or dialysis patients, and we check a blood gas to check for potassium, but automatically you get an abnormal blood sugar result, regardless of whether they have diagnosis of diabetes. If we know the result, it fits into this protocol that they should be treated in some way, and we'll get into the exact details. The addition and the big change, well, it's not a big change, but it's a clarification, I should say, and some changes have to do with clear description what needs to be done on a patient with an insulin pump, and I'll get into the details of that. Also, this new guideline provides some guidance in terms of what to do with patients who have very high blood sugars. And this is an effort to standardize approach to either delaying or canceling the procedure. Of course, at that point, we're talking only about the elective surgeries because emergent surgeries would still need to proceed. And we'll talk in more detail about what are the actual interventions for patients with the blood sugars less than 350, because those are the ones that potentially need some treatment in the pre-op area. So again, just to summarize, we're not changing the criteria for testing in the pre-op. They're going to stay exactly the same. If the patient has a known diagnosis of diabetes, we will check a blood sugar. If you happen to check another lab and the blood sugar results and it's abnormal, we would follow exactly the same protocol. I mentioned some of the changes in the preoperative insulin pump guideline. And I also want to provide you with some rationale behind those changes. Historically, when anesthesia approached these patients, our preference was to take full control over the patient's glycemic management. And that meant removing the pump completely and switching them either to the sliding scale insulin or starting them on some form of the infusion. A lot of the time, this actually does more harm than good for the patient because patients on insulin pumps, they're usually very well versed in terms of their glycemic management, and they like to take active care in their own in their own management of blood sugars. They usually pay very close attention to the frequency of checks, and they have figured out ways of how to manage it successfully for the most part. So the big change here is that Previously, the default was to remove the pump, the insulin pump in the pre-op area. Now the default is actually going to be to keep the pump and let the patient make some of the changes if they desire. There's some recommendation like setting the basal rate to about 70%. And there are some preoperative instructions for the patients. And there are some exclusions that would still require removal of the pump. Those exclusions involve either technical reasons or potential causes that would incapacitate the patient and preclude them from participating in their care. So from the technical reasons, any procedure that requires the use of ionizing radiation, for example, C-arm, CT scan, X-ray, the pump should be removed, and that has to do with just the mechanical limitations of the device, really. They should not be exposed to ionizing radiation. But also any patient that is expected to remain intubated or expected to remain deeply sedated after the procedure and will not be able to make adjustment to their insulin pump, will not be able to actively manage the pump post-operatively. In that case, it would be appropriate for us to assume full care over glycemic control. And then anytime the pump, the physical location of the pump is actually going to interfere either with the patient positioning or is going to be located proximal to the incision site. That's really the major change about the insulin pump management that would involve the pre-op area. The second part that I want to mention before getting into the details about the exact dosing of the insulin in the pre-op area is what happens to the patients who have very high blood sugars. And one of the things that was done here is to actually define what it means, abnormally high blood sugar. And the agreement was that anytime a blood sugar is above 350, that warrants some sort of either pause, for sure, discussion and potential intervention, either in the form of canceling surgery or proceeding with certain contingencies in place. Now, when we do have an abnormally high blood sugar, as I mentioned, above 350, it is important to differentiate what type of diabetes the patient has, whether it's a type 1 diabetes versus a type 2 diabetic patient. With a type 1 diabetic patient, there's going to be an additional step. And the additional step is going to be checking for the urine ketones. This can be done by a simple urine dipstick. Formal labs can be sent if necessary, but this is meant to make sure that the patient is actually not entering the diabetic ketoacidosis stage. It would be inappropriate to cancel a patient like that and send them home because some of those patients will definitely need insulin started, but also they may need initiation of the ketone protocol and potentially admissions through the ER just for the purpose of the glucose management. So they do require a little bit more refined care. Patients with type 2 diabetes, if they do have high blood sugar, and the ask here would be to notify the surgical team. The ask here would be to notify the anesthesia team. And then they have to make a decision whether it is worthy with proceeding with surgery. Typically, if it's an elective surgery, a cancellation would be recommended at that point. Obviously, if it's an urgent or emergent surgery, this may not be an option, but the plan has to be formulated in terms of how to manage this blood sugar more aggressively and what additional steps need to be taken. From the standpoint of the pre-op nurse, your threshold would be if blood sugar is above 350, you need to notify the primary team, both surgery as well as anesthesia, in terms of how to proceed and see if you can catch this distinction between type 1 and type 2, because again, they do require different treatments. The bottom line is blood sugar of 350, stop, notify, this needs further consideration. Now, let's talk about exactly how we're going to support this workflow in the pre-op area. The changes that are associated with this protocol have to be reflected in the order sets. Those order sets have been created. Again, we've been vetting them through various groups, including the peri-op nursing. They're not live yet. And my best estimate is probably sometime in September, they're going to go live because we still require education of providers. We still need to make sure that those orders exist within the all of the booking orders that are placed by the surgical services. But this is what the ordering providers are going to see. There's going to be a section on blood sugar management, specifically as it pertains to the pre-op area. It will contain guidelines, and it would, my preference would be to actually provide with a shorter workflow or shorter protocol in addition to a full guideline, because I think people just want some quick reference available as well, in addition to that massive 56-page document. There are some reminders here, and then we ask to click whether it's an inpatient or an outpatient type of procedure. These are the exact details of the orders, the way they're going to be entered from the pre-op standpoint, and this is the actual logic behind them. And I'm just providing the slide for reference because this one is probably much easier to see than trying to decipher it from the individual order sets. This correlates, this is identical to what is listed in that initial, I can scroll back, in this box. So this box is actually fully supported with the order set. So we're not expecting for you to go outside of the order sets to know exactly what is the appropriate intervention here. Now, the intervention here is actually very simple. It's a sliding scale. It's a sliding scale for a sub-Q insulin. And the dosing protocol is relatively straightforward, but there's no, not much difference between any other sliding scale that you have been exposed to previously. So I want to go back to this slide briefly and basically just summarize it here. So no changes in terms of who gets tested for blood sugars in the pre-op area. Insulin pump does have its own guideline. The default would be to keep it on. If the blood sugar is above 350, that warrants a pause notification to the anesthesia as well as the surgical teams with some guidance in terms of how to proceed. And if the blood sugar is less than 350, we're not going to initiate the treatment until the blood sugar is above 180. This is the threshold for initiating therapy. And this threshold is actually going to stay the same for pre-op, intra-op areas for inpatients. And this is an important distinction because we don't want to be as aggressive with the outpatients because potentially we're not able to keep as close eye on the outpatients. If the blood sugar happens to be less than 70, the hypoglycemia protocol gets activated and requires some supplementation with D50. Again, this is supported through the orders. And if we do give insulin in the pre-op area for the blood sugar greater than 180, and again, this is a sliding scale, the only other requirement that comes into play is that once we have administered insulin, the blood sugar should be rechecked every 2 hours. Again, this is not an expectation that the patient will be sitting in the pre-op area for that long, but if they happen to stay in the pre-op area, you will be asked to recheck the blood sugar. And again, this is actually supported through the individual order sets here, both in terms of notification to the physician teams as well as rechecks. Now, what's going to happen to this patient after they leave pre-op? And again, in pre-op, the only treatment that you will be initiating on this patient is sub-Q insulin. You're not going to be asked to start insulin infusion on those patients. You're not going to be asked to keep treating them beyond a reasonable initiation, really, because frankly, I don't think most of the patients are going to be spending that much time in the pre-op area to require every 2-hour adjustments. From the anesthesia side of things, once we have the patient in the operating room and we know that the blood sugars have been abnormal and we may be checking them for various other reasons, especially if we have an arterial line in place for invasive blood pressure monitoring or any other reasons we draw the lab. If the blood sugar exceeds that threshold of 180, this is when we're going to start treating. Now, intraoperatively, anesthesia service, the best way for us to do it is to actually start the patient on insulin infusion. So insulin infusion will be initiated for any blood sugar above 180. We will be stopping the infusion anytime they reach 70 to 120. So basically 120 or less, we would be stopping the infusion. But anything above 180, we will be initiating a bolus as well as starting the drip. And I have to say the protocol here is very, very conservative. And this is meant to err on the side of safety, really. And this is just a disclaimer here to say, obviously, if glucose is not responding, consider increasing the rate and increasing that titration. But this is really meant to be the minimum starting reference for the insulin infusion. Now, as we approach the end of the case, this is the point where we have to make a decision whether we want to stop the infusion, the insulin infusion altogether, or whether we need to continue the infusion into the PACU and potentially into the inpatient area afterwards. And the decision point here, obviously, if the patient is a type 1 diabetic, they would need to have some continuous supplementation of insulin. They may have an insulin pump. If not, we will have to continue the infusion. But vast majority of patients are going to be type 2 diabetics. And the decision point here is that if the infusion is equal or less than 2 units an hour, then we can actually stop the infusion and bring the patient without the infusion to the PACU area. However, if the patient is still requiring, meaning their blood sugars are still above 180 or not less than 120, and the insulin requirements are continuous and above 2 units an hour, then the patient will come to the PACU area with the insulin still being infused. And the ask is then what happens to the patient afterwards. And this is a complicated diagram, but I'm going to do my best to simplify it for you. The top portion obviously divides the patient, whether it's a type 1 or type 2 diabetic. But the top portion is really meant to cover the reminder to recheck the blood glucose in the PACU, especially if the patient has been treated with insulin in the pre-op area, or if infusion was running intraoperatively. Now, again, if the patient was given sub-Q area in pre-op, the requirement is rechecked within every 2 hours. If it's a type 1 diabetic, the requirement is actually to be checking it every 1 hour. This is meant to cover somebody who was not started an insulin infusion. So basically, potentially somebody got a single dose of sub-Q insulin in the pre-op. They kept rechecking the blood sugars intra, but did not have to start the infusion. You are still obligated to do at least one blood glucose check. Now, you don't need to wait 2 hours in the PACU to do it. As long as that fits within the 2-hour frame of, you have to recheck it 2 hours after the initial administration of insulin. And in that case, the time 0 would be the time when the insulin was given in the pre-op area. And this is probably more of a concern for the outpatients rather than the inpatients, to be honest, because inpatients usually, as you can imagine, the duration of surgery plus the duration of PACU stay would usually exceed by far this 2-hour requirement for the recheck of the blood glucose. The most important, I would say the most relevant thing that's going to happen much more frequently is what happens when the patient comes out from the OR, is whether or not they're going to have an insulin infusion going. And this is the branching point that's important. So patient was appropriately addressed in pre-op, managed intra-op, are they coming out with insulin infusion or not? And again, the cutoff for the intra-op portion is, are they requiring greater than 2 units an hour of insulin? If they are, they should continue on the insulin infusion. If it's less than 2 units an hour, then the infusion should be stopped. If the infusion is stopped, if the patient is coming out without insulin infusion, then they're being transitioned to the sliding scale sub-Q insulin. If they continue on the infusion, then they should continue that infusion in the PACU area, and then you have the infusion titration protocol for the PACU. Again, the protocol itself is very conservative, and it may need to be adjusted based on the individual response of the patient. Same question as in pre-op, what do we need to support this workflow? And the answer is we need to be changing the PACU order sets. And the PACU order set need to be reflective of all of the changes that I've just described in the guidelines. So this section is going to be added to the PACU order set. These ones are going to be placed by anesthesia. And you can see that there's both inpatient and the outpatient sides. Right now, we're discussing inpatient side only. And the orders, this is how they're going to look like. Again, they're describing the same changes as I've outlined in the actual diagram, but this is a cheat sheet, if you wish, and a cleaner reference slide that you can refer to as needed. This is the sliding scale. This describes when do you initiate. Again, the thresholds are staying the same consistently across the board. We want to be standardized as much as we can. Only the blood sugar above 180 requires the intervention in terms of insulin administration, and the recheck times are staying the same. Same thing with the low blood sugar hypoglycemia protocol starts to come into play. This is not any different that you would do today. If the patient requires an insulin infusion, then it's going to be under inpatient. Instead of subcutaneous insulin, this is going to be insulin infusion. And again, you have the order set that would support that workflow. And again, this is the reference point, just in more clear detail, so you can refer to as needed to see exactly what type of titration needs to occur. Are there any questions about the inpatient side? And I want to pause here before I jump into the outpatient side, because I think that's a good stopping point right now to take any questions or any or address any concerns.
We do have one question. Is this going to be part of the handoff that you know of?
It should be. It should be 100%, because you do need clear communication. And again, somebody needs to be entering those orders, because the orders are not the same for, you're going to have patients who are either need the sliding scale or need insulin infusion. So it has to be entered appropriately, no question about it.
Sure. Anybody else have anything? And then I guess the next question would be, are those orders, they know to put those in the correct patient phase of care?
Yes, especially for the PACU and especially for the pre-op, yes. That's, again, this is going to be contingent on when the orders are actually being rolled out, but that's something that we would have to check and verify.
Okay.
And the only other thing that I forgot to mention is what happens to these patients afterwards when they're actually ready to leave the PACU. If they're still requiring insulin infusion because their blood sugars are still high, the expectation would be for them to transition to the floor on insulin infusion. I see the question in the chat, when will we start to see this in our orders? As soon as we go live, which I understand it's been delayed several times already for various reasons, but what we need to do is to roll out, do the same education and roll out for anesthesia providers, and then actually activate the orders and make sure that they're working the way that we expect them to work. If all goes well, I anticipate mid to end September, we should be live with those orders. Part of the reason that I'm hedging is because, unfortunately, the guideline for the outpatients has not been released, unlike the guideline for the inpatients. And my preference for the perioperative areas is to actually do both at the same time, because you really cannot ignore a fairly significant portion of the population that's going through the operating rooms that are outpatients right now, and something needs to be done. So I'm happy to share with you what has been discussed within anesthesia, and we can definitely release it in the perioperative areas. But this is not, like I said, this is at this point, this is just an internal guideline. This is not a hospital-wide guideline. I don't expect the hospital-wide guideline to change because, again, the consensus was that this is what the perioperative areas are going to do. And all of the elements from the inpatient side have been incorporated on the guidelines. So I expect the same will happen with the outpatients. So this is what we have created internally. Internally, I mean, within the perioperative area, not within the entire hospital enterprise. But the intent here is for it to be applicable to all of the outpatients, as I mentioned before, not just the ambulatory setting, but any outpatient that is done at UH, any outpatient that is done at the CBC. So all of the adult patients going through the perioperative areas here. So from the standpoint of who is getting tested, same guidelines. We're not making any changes. Any patient who has known diagnosis of diabetes, or anytime you get a lab that results in the blood glucose that may be abnormal. Same guidelines applies to the insulin pump. We're not changing anything there. And same guideline applies to and same thresholds apply for potential cancellation of surgery. So threshold there is any blood glucose above 350 warrants a pause and a discussion. And I would say that majority of the outpatient procedures may end up being canceled because of that, unless it's something that cannot wait or something that is very challenging to manage on the ambulatory side, but we'll see. Blood sugars less than 350. This is again where we're asking to do an intervention. Now, unlike the inpatient side, the only intervention that is going to happen on the outpatient is going to happen in the pre-op area. We're not asking for any intra-op rebolusing. We're not asking for any PACU rebolusing of insulin. The best time to do it is to actually check the blood glucose and pre-op. If it is abnormal, address it right there. So there is a sliding scale. The sliding scale is more conservative than the sliding scale used on the inpatient side. Again, we're not trying to be overly aggressive about it. So you can see that the threshold here is not 180 for treatment. The threshold here is actually 250, above 250. So 251 and above warrants some sort of intervention via the sliding scale. This is a sub-Q insulin administration. We're not starting an infusion. We're not doing anything else. The ask here is to check the blood sugar once, treat it if it's abnormal, but only initiate the treatment if the blood sugar is above 250. And it really needs to be within that range of 250 to 350, because again, above 350, you should be considering canceling or postponing the procedure until blood sugars are much better controlled. Not much difference for the patients with hypoglycemia if the blood sugar is less than 70, that warrants some treatment in the recheck. And the recheck for the sub-Q insulin here is actually the same as on the inpatient side. Again, we're trying to be consistent, not to cause a lot of confusion. So every 2 hours requires a recheck. Now, this recheck is probably more relevant for the outpatients because some of the outpatient procedures may be of shorter duration. Maybe not on the UH side, but as you can imagine at Kellogg, or some of the ECT procedures may be relevant where the procedure itself is only 15, 20 minutes long, right? And the patient didn't spend enough time in the pre-op. This potentially may affect their PACU stay a little bit because you are required to recheck the blood sugar after 2 hours of the initial administration of the insulin. Most of the cases, this is not going to be an issue because it does take longer than 2 hours typically from the pre-op all the way to the ready to be discharged from PACU, ready to be discharged home really, or to some other either short stay unit. Well, short stay unit technically should be treated almost as an inpatient. The outpatient order set will look slightly differently, but the orders are very similar in terms of how they're going to appear. The only difference is, again, less aggressive sliding scale. And this is the actual breakdown and sort of this reference sheet for the outpatient protocol. Again, the biggest change from the inpatient side is when you're initiating the sliding scale insulin here. For the PACU side, intraoperatively, we're actually not going to do anything for those patients in terms of starting the insulin infusions unless in a very, very rare cases when the blood sugars are very abnormal and somebody may choose to start an infusion, but those should be really true exceptions. I don't expect majority of cases actually fall into that category. So vast majority of patients, we will be rechecking the blood sugars, especially if the patient was treated in the pre-op area with sub-Q insulin. Intraoperative anesthesia is responsible for doing those checks. We're required to do it every 2 hours. Especially for longer duration cases. If that recheck has happened in intra-op, you actually don't need to do much. It's always recommended that we document at least one recheck in the PACU, but you don't necessarily need to wait for another 2 hours since the last check or anything like that. As long as we've waited 2 hours from the initial insulin administration and pre-op, whether that recheck happened intra-op or whether it happened in PACU, it does need to be 2 hours afterwards. But regardless of whether it happened, we have satisfied that requirement. So the PACU is really just asked to recheck the glucose. That's it. You're not expected to reinitiate the treatment because the patient is going to be going home. And this is done strictly just to pick up any unintentional or iatrogenic hypoglycemia that might have happened from the insulin treatment. And if the blood sugars are above 70, they can be very high sometimes, but it is not the intent to actually treat them in the PACU at that point. Again, unless it's highly, highly abnormal, which should not happen if we've done everything properly in terms of vetting the procedure and vetting the blood sugars beforehand. And again, very similarly to the inpatient order set, there is a separate PACU order set for glycemic management, but specifically for the outpatients. And this is not meant to initiate any type of treatment apart from the hypoglycemic protocol. This is only meant to actually recheck the blood sugar. And that's really all I have in terms of the update. And again, I'll open it to any additional questions, either about the outpatients or about the entire glycemic management changes, really.
Do we have any questions? He was we said like the end of September, maybe for go live for this, do you think?
I would say so, and I will give you a fair warning. Again, this is, I'm not a big fan of surprising anybody.
Yeah.
I
think I know Irina is saying that we've already seen maybe a little bit, but I think that, you know, we're going to be prepared to get our education out to our nursing staff as far as those changes in the order set and whatnot. And, you know, hopefully then anesthesia's up to date and we'll all be ready. So.
Yeah, and the thing is, the orders themselves, they're not anything different from the sliding scales or insulin infusion sets that we've used before. It's just historically we've used them very inconsistently, and people were free to choose whatever set they want, or sometimes entering them ad hoc. And this effort really should be just standardizing it all across the board. But I think it's important to understand some of the background information and some of the rationale that went behind into creating these order sets, because as I said, the main thing is that we are treating inpatients the same way and we're treating outpatients the same way all across the enterprise. And more importantly, that we're actually integrating them into what happens to those patients afterwards, especially on the inpatient side, so that we instituting an early intervention with the expectation that this is actually going to carry through their inpatient stay. So that's really the goal here. But individual details, I think you're very versed in terms of trying to decipher the protocols or going through the order sets.
Awesome. Thank you so much, Dr. Dubovoy. And if you can, if you'd like to share your slides, and then we can provide those to our staff as well, just so we can review at the same time too.
I will send them to you right now.
Okay, great. Anybody else have any other questions? Okay, thanks for your time again, and we appreciate it.
My pleasure.
All right, take care.
Bye.
Thank you. Bye-bye.